What sort of insights, you've done a lot of pioneering work, Steve, in intravascular ultrasound. What sort of insights does IVUS give us in terms of plaque, when it starts, what can affect its progression?
Well, first of all, one of the most eye-opening things that happened in my career was when we first started putting intravascular ultrasound probes into the coronary, about 1990 or so. And I always thought of it as a plumbing disease. I thought the way that some interventionalists maybe still think, that
Well, even doctors or people in general oftentimes still think of it as the pipes being clogged up.
yeah. And so you get a stenosis, and that causes symptoms, and you get a stent, and that makes the symptoms go away. But what happened was we started to put these IVUS probes down the coronary, and oh my God, every millimeter of the vessel was atherosclerotic. Most of the plaque was not intraluminal, it was remodeled outward, but the entire artery was atherosclerotic. And we did a study, my colleague Murat Chushu, now in Abu Dhabi, led that study, a really thoughtful, wonderful guy. And he did a bunch of IVUSs in fresh heart transplant recipients. So he's looking at the donor hearts. The average age was about 30 years of age. And over half of those hearts at age 30 had major plaques in the coronaries. And so this disease starts very young. It's part of the reason why I've come to this thought process about treating earlier, is we know the disease starts earlier. In fact, in his study, 1 out of 6 teenagers who died in motor vehicle accidents, we looked at them with IVUS, they had plaques in their coronaries. 1 out of 6 teenagers. And so this disease, when patients come in with a myocardial infarction at age 45 or 50 or 55, the disease has been there for 30 years.
So Jamie, you do a lot of primary prevention. What are your thoughts? Because Steve is quite right. The plaque starts pretty early, even if you think back to the Korean sort of war autopsy data. There's plaque in young folks for sure, even ones that are ostensibly quite fit and healthy. Is this something we should treat on an individual level, a public health level, both? What's the role of diet, lifestyle? Is that going to be enough? Does it always have to be pharmacotherapy? What do you think?
So I think well, first and central is actually screening. And not enough young people are getting screened at early ages to understand whether or not they're at risk. And I always remind people, we screen as early as age 9 to 11 in this country, yet it's not getting done often in a lot of pediatric practices. Now that's to pick up inherited forms of high cholesterol, which is much more common than people think. But when you add in lifestyle, diabetes happening at early ages now, not later on in life, clearly the role for prevention is more than just putting people on medicines. It's identifying risk factors and intervening as soon as possible. And so diet and lifestyle does play a role. It plays a role even in people with inherited disorders. And your colleagues at Harvard have shown that very nicely, that in people with inherited causes of early atherosclerosis, those who live heart-healthy lifestyles have a reduced risk. They don't eliminate risk, but they reduce risk. And so it's a combination of intervening with diet and lifestyle as early as possible, but at the same time, intervening pharmacologically when necessary.
So not an either or.
I want to circle back, if I could, just for a second, because we left it very quickly. And I'd like to hear what others have to say, but I've been very disappointed with how much I can move LDL cholesterol with diet. As much as we all say diet and lifestyle first, why am I bringing this up? Because if you go to family practice in general internal medicine, everybody's got it in their head that when you see hypercholesterolemia that you always should try diet and exercise first. And so some guy comes in at age 50, tons of risk factors, and an LDL of 150. And they're said, well, your cholesterol's high, we're going to try diet and exercise, and I'll see you back in 6 months. And maybe they don't make the appointment for a year or two, and the next thing you know, they're coming in with a myocardial infarction. Let's be realistic here. Maybe on average you can get a 10 or 15% reduction in LDL with diet. That's not trivial. It's equivalent to a several-fold increase in statin dose. So what I tell patients is, you should diet and do these other things, because I may be able to control your LDL with 10 milligrams of atorvastatin if you do these other things, and it may take 80 milligrams of atorvastatin to control your LDL if you don't do these things, because of the rule of 6. Every time you double the dose, you get 6% more LDL lowering. So But I think it's important that we communicate crisply to the generalists that you can't, with really high LDLs, you're not going to get them there unless you actually early on you got to go to.
So you've raised a great point. There are a lot of primary care physicians that are watching this program, so we've got to make sure we give them a clear message.